Okay, so I was invited here to talk to you guys about adult vaccines. And I think my title kind of says it all. Immunizations are for adults too. We have a tendency to think that when we get vaccinated as babies, that's the end of it for the rest of our lives. But times they are changing, and it's really important to maintain your vaccine status for your entire lifespan. These are all my favorite websites. If any of you are interested and you want to send me an email, I'm happy to send all these websites to you. So this is where all my sources are for all my information. And there's also a lot of really good sources on those websites for the public as well. You can just point and click, as I'm sure you all know with the Brookhaven Labs, with the education you guys do for the public. In fact, my connection to Brookhaven Labs goes back when my children were about 7 and 8 years old. We came out here on one of the weekends for one of your tours. And I wound up with a technology education teacher who's now looking to segue into computer engineering because teaching is a dead-end career these days. And my other son is a quantum chemist who's got a PhD in quantum mechanics. So I'd like to think that some of the fun things that they saw here had something to do with both of them choosing careers in science. Okay, this is CDC's immunization site. Again, anything you ever want to know or ever thought you might, don't even know you wanted to know is on that website. All right, so we're going to talk about what vaccines are, and I just wanted to show you this. This is what we healthcare providers use to guide us with what we're determining you guys need for vaccinations. And we never even had an adult immunization schedule until a few years ago when we decided, I think it's time, because a lot of adult providers really don't know very much about vaccines. It's really us pediatric folks who were always so focused, and we've kind of used the knowledge that we have as pediatric providers to share the wealth with our adult provider colleagues. So if you look down this list here, you'll see an awful lot of vaccines. Influenza, tetanus, diphtheria, pertussis, chickenpox, HPV if you're within that specific age range. I didn't bring information on HPV, but I'd be happy to answer any questions if you're interested, because actually the biggest cause of head and neck cancers in the United States, which is becoming a huge problem and a very rapidly increasing problem, is HPV-caused head and neck cancers. In fact, a very good friend of mine just lost her 42-year-old son to tongue cancer related to HPV. Okay. Zoster, which I'm sure you're all interested to hear about, which is the shingles vaccine. Terrific vaccine, which I think all adults, once they hit that 60th birthday, need to get. Measles, mumps, and rubella. Measles is a big problem now in Europe, and these diseases are only a plane right away. Pneumococcal polysaccharide vaccine, which is one of our 2 pneumonia vaccines, which is really important, and I have a lot of information on that for you guys today. Meningitis vaccine, specific populations, but you might be a candidate after you listen to what I have to say. Hepatitis A, if you eat sushi, you should get hepatitis A vaccine. My friends in CDC were like, we don't eat that because we know what's in it. And I said, well, I'm going to eat it anyway, but I'll get my hepatitis A vaccine. And, of course, hepatitis B vaccine, which is becoming a larger issue for some adult populations. Now, these are disease-specific. If you have any of these conditions, and you look down the row here, you'll see that there's a tremendous number of vaccines that for each of these specific conditions are indicated. Now, I just threw this up too for 17 to 18-year-olds because we consider them, it's kind of like an overlap of who takes care of the 7-year-olds to 18-year-olds. Most of the adult providers start at like 15 or 16, but some of them are the family practice folks seeing children younger than that. But if you have people in this age range in your families, certainly it's something to think about. All right, hepatitis B. This is a growing problem. And if you have diabetes and you fall within a certain age range, you're going to be a candidate to get a hepatitis B vaccine. So you might say to me, well, jeepers, I don't really have exposure to blood. Why do I have to get hepatitis B vaccine? Since 1996, we've had 29 outbreaks of hepatitis B related to blood glucose monitoring. And we all know that not everybody is fastidious about cleaning blood glucose monitors, especially when you're living either in a group situation or even going to a practice where it's not just one, like the practice is using the blood glucose monitor for more than one patient. So we have had contamination leading to hepatitis B. So there were 865 cases among these diabetics 23 through 59 years of age. So, CDC loves numbers just like all of you do, and they said, well, wait a minute, we have to do something about this. So now when we looked at and you guys know what NHANES is, right? The National Health and Immunization Survey. Anything you ever wanted to know about health information in the U.S. for data collection, you can find there. I love that source because when I'm looking to write papers, it's the first place I go to get my data. So when they looked at that NHANES survey, they found that the infection with hepatitis B was 60% higher among diabetics compared to non-diabetics. So what the CDC decided to do was take a look at those numbers again and recommend that any diabetic 19 through 59 years of age get the 3-dose series of hepatitis B vaccine if they had not already done so. And then, of course, the hepatitis B vaccine is an option for those 60 and above. Quite frankly, as a public health nurse, if I had diabetics who were living in a group home, or if I was in a practice where we used one glucose monitor for checking all of our patients when they came in for their regular visits, I would give them hepatitis B vaccine anyway. Because when you look at risk-benefit, it's a lot cheaper and a lot better for your health to use the vaccine than have to worry about somebody coming down with hepatitis B and all the complications. Because we know hepatitis B is one of the leading causes of liver cancer in the United States. We're really fortunate here in the U.S. that we have vaccines that are really anti-cancer vaccines. Among them, hepatitis B and HPV vaccines. All right. Now, I want to talk to you about whooping cough. I don't know if you've heard, but we have a real big problem here in Suffolk County with whooping cough. We have close to 1,000 cases in Suffolk County within the last year and a half of whooping cough. Not a very good thing. Now, if you look at this little graph, when I went to doctoral school, I learned all about how to look at numbers and how important the numbers were to document what we're doing. So I really bring a lot of numbers with me now when I come to talk. All right. Now, if you look at this graph, you'll see what happened. And it dropped off the last digit, and it was the ones in between, some of the numbers in between when I cut and pasted this from CDC's website. But this is 2011. This is 2000. This is 10, 2009, 8, 7. So if you look here, you'll see that we did a really good job. In the years ago, pertussis was a big problem. And then we did a pretty good job. And then all of a sudden, in 2009, we started to see a blip in what's going on in 2005. And if you look at this, this is kind of the blown up section of this little piece here. And look what happened. So, again, we looked back at the data and said, well, what's going on here that's causing this? All right. So what is pertussis to begin with? It's a prolonged cough. They don't call it the 90-day cough for nothing. A colleague of mine picked it up from a baby that she was seeing, and she coughed for 3 months. We were at a conference together, and she went in the bathroom and tried to hide at night, but I could hear her coughing in there. But when you're not coughing, you're perfectly fine. You don't even know that you're ill. But the problem with it is what we're seeing now is more in the adult and the adolescent community than we are even seeing in the babies. The babies die, but big people get really sick and they spread the disease. And any adult who throws up after they cough has pertussis. Post-tussive vomiting is, we call it pathognomonic, or a clear indication that if you throw up as an adult after you cough, you have whooping cough. Now, it really takes several medical visits, lots of evaluations, because adult providers don't really think whooping cough for adults. They think, oh, community-acquired cough, all other kinds of things. And when they go to treat it, they treat it with the medications that we normally would treat with whooping cough. We use azithromycin. Well, that's the drug of choice for whooping cough. Now, what we'll do is we'll stop the transmission, but you're still going to cough for 3 months, and the adult is like, cheapers, I don't understand this. And then before you know it, you're trying different antibiotics, and we all know. You guys are involved in a lot of this research yourselves with, what goes on when people misuse antibiotics. So it's really important to get the appropriate diagnosis. Costs, missed work, public health system. Every time we get a case of whooping cough, our public health nurse epidemiologists have to do all the tracking and following. And they have 2 nurses dedicated to doing nothing other than tracking these whooping cough cases here in Suffolk County. And we all know what's going on with the tax dollars these days. So better use those dollars for something else other than tracking and diseases that we can really stop in their tracks with vaccines. Okay. Now, this one doesn't kind of show up too well because the lights are on. But what I wanted to show you was how the incidence is increasing. Here we are in New York up here. And if you look, this is where we are, 6.6 to 10.2 thousand cases annually. Now look what's happening. We're up to 7. We're up to over 7,000, almost 8,000 cases in New York State, according to the 2011 data. Now this is the same slide that I showed you before, but it's broken down by age group. So now if you see these little with the 3 hash marks on it, this is so a lot of our cases, because the pediatricians are really looking for them and looking to diagnose. But if you look down here, look at all these older age groups and how we've had an exponential increase in all of those cases. And that's because we're really working on the adult provider community to increase their awareness, to be thinking a cough that's lasting more than 3 weeks is probably whooping cough. All right, so now, I'm sure you've also heard in the news lately that we are having some issues with the effectiveness of the vaccine. My babies and I were all vaccinated, and I'm sure most of you are, with the old wholesale vaccine. But we didn't like it because it caused fevers and it caused febrile convulsions and red, sore, swollen legs. So they tried to find a better vaccine that would still prevent disease but not cause all of those after effects. Well, they came up what we call with our acellular vaccines. What they were able to do is take the little piece of the bacteria that causes the immune response and get rid of all the cell debris that was causing all of, or what we thought was causing all of the side effects. We thought that was not going to affect the immunogenicity or the immune response to the vaccines. But now that we're over 10 years out of having had those vaccines, we're starting to see a drop-off in the immune response. You get a great immune response to the vaccines immediately, but then quite rapidly it starts to drop off. We used to think that 10 years was a good amount of time between booster doses of pertussis vaccine, but now that we're starting to look at the data, we're finding that isn't, it really isn't realistic. The drop-off starts to occur within 3 years of the receipt of the vaccine. So the Advisory Committee on Immunization Practices is starting to look at that data. And I'm guessing, if you ask me to rub my crystal ball, that within the next 12 to probably 18 months, you're going to see a change in how often we're asked to go back and get booster doses so that we can get a good high level and keep that level high of good response to prevent pertussis. So we think that might be playing a part in this outbreak that we've seen. Because years ago, it used to be every 3 years you'd get an outbreak of pertussis. That was the natural cycle of the bacteria. And now we're kind of starting to see that again, and we think the immunogenicity of the vaccine is starting to play into that. Okay, so right now, the best thing that we have to fight whooping cough is the Tdap vaccine. I got it. I wouldn't think of going near children without having had the vaccine. And you might have children in your families, or even if you go shopping in the mall, you're going to be exposed to children, which is where, and the children are really the incubators because it's in the schools. They come together in school, they share everything, including their germs. So if you're anywhere around children, even if you think you're not around children, children are in the environment, especially once they're in school, because we also see a drop-off, and we saw the drop-off in our statistics with whooping cough. Once school was over, we saw a drop-off, and then when school came back in session, we started to see the numbers rise again. So we want to make sure we get Tdap into everybody, okay? Once you're 7 years old, or older, if you've never had at least one booster dose of pertussis-containing vaccine, we want everybody to get a booster dose. We also are vaccinating pregnant ladies against whooping cough, and that's to prevent them from giving whooping cough to their babies. Because if we vaccinate them in the 2nd or 3rd trimester, that gives them a good immune response so that the baby gets some passive immunity, and that also the mom won't expose the baby to whooping cough as well. Because we don't start vaccinating the babies until they're 2 months of age. And then it takes us until they're 15 to 18 months to finish the 4-dose series to give them about 86% protection against whooping cough. So we want anybody who comes near children to be vaccinated. First of all, we don't want you coughing for 3 months, but we also don't want you coughing and possibly infecting babies. Okay, now, you might say to me, well, I just got a tetanus shot a while ago because, Medicare Part D, or your parents or grandparents, Medicare Part D does pay for tetanus diphtheria vaccine. It also pays for Tdap. But like I mentioned to you before, a lot of the adult providers are not aware that they should be giving whooping cough vaccine to adults. So maybe your grandparent or your mother or your father went and got just a tetanus diphtheria shot, but didn't get the pertussis component. So how soon then can they come back and get that pertussis component? They can come back the same day. The CDC and ACIP has now eliminated the interval between receipt of a TD vaccine and a Tdap vaccine. You know, I tell people all the time, if your provider accidentally gave you TD in the morning, you can go back for Tdap in the afternoon and get it in the other arm, and you're going to be perfectly fine. Okay, there's no more interval. You might have a slightly increased chance of getting a red swollen arm, but generally speaking, that is of the lesser of two evils than having the chance of you coming down with whooping cough. Now, if you take the package insert out of the box, it says one of the two vaccines is licensed for from 10 years old to 65 and above. But ACIP always does what they call harmonizing schedules. So what they do is they say, well, if this vaccine is pretty much the same as that vaccine, even though it's made by a different company, we're going to give the two vaccines and treat them pretty much interchangeably. So it doesn't matter which vaccine your provider carries, you can get a Tdap vaccine when you go to your provider. Okay. Some of the insurances are covering, I know our insurance in Suffolk County Department of Health Services, we're self-insured, and it does cover the Tdap vaccine. And my understanding is, because you know, when I sat on that ACIP, on NVAC, on the National Vaccine Advisory Committee, one of the things we talked about was vaccine financing. And my understanding was employees of the federal government, the insurance does cover the Tdap vaccine for their, you know, for their care. Now, if you don't know whether you've had a Tdap vaccine or not, you just should get the Tdap dose. Right now, it's a single dose, but I can almost guarantee you within the next, probably not more than 2 years from now, probably a lot less, all we're going to have available is the Tdap vaccine, and the booster interval is going to be shortened to probably anywhere between 3 and 5 years. I'm guessing, if you asked me to guess, I would say probably 3 years based on the vaccine, because we don't want to go back to the old wholesale vaccine. But we want to do something with the new vaccine while they're working on technology to make the vaccine more better stimulating to the immune system. They're going to come up with giving us booster doses more often. Now we talked about pregnancy, measles. Okay, I was really worried that we were going to see a lot more measles when people came back from England this summer, because measles is endemic in England, Scotland, Ireland, France, Italy, and Spain. And that's because of that big scare that was over 10 years ago with that Wakefield person who doesn't even deserve the title doctor, which has been stripped from him in England. He falsified a study, and we all know about, you know, I mean, I do research. I'm sure all of you are involved in research, and we know how rigorous the process needs to be. And a study was published for him that did not take that into consideration, and it was a falsified study. And what it did was scare the daylights out of parents and make them very fearful to give MMR vaccine to their children. He tried to claim that the MMR vaccine was the cause of autism, and that's been totally discredited. But meanwhile, we're still stuck with the aftermath, and parents, they're doing a lot better job now in Europe of vaccinating children, but there's this cohort of young adults who were never vaccinated against MMR, who are the prime source of measles in Europe. So if you're going to Europe, I'm going to tell you you need shots for travel, and what you need to do is make sure you've had at least 2 doses of measles vaccine. And you're going to get 2 doses of MMR because we don't make single antigen anymore. So if you're going to Europe, please just make sure you've had 2 doses of measles vaccine, because you do not, first of all, you don't want to get sick with it because you're going to be miserable. Measles disease kills people. You can get measles meningitis, you can get measles pneumonia. My own sister was so seriously ill from measles disease when I was a little girl. I remember watching her, and I think my mother was really frightened that she was going to die, and I really think, in retrospect now, she did have measles meningitis. Based on what I remember seeing as a little girl, and I can remember it like it was yesterday. So please, if you're, you know, make sure that you get measles. Make sure if you have relatives, children, that everybody has measles vaccine. We've had 156 cases in the U.S., and this is just the data from January to June of 2011, which is all I could get off the CDC's current website. 139 people were U.S. residents. 86 were unvaccinated. And I forgot one other country. Israel also has a huge outbreak with measles. Went to these countries, came back with measles, and then not only were sick themselves, but infected a lot of other people as well. 30 of them, we couldn't figure out what their vaccination status was, so they most likely were unvaccinated. So 136 of these cases were clearly documented to be importations from other countries. And 133 were unvaccinated and had no documentation. So what that says is we really need to do a much better job of getting vaccinated here in the US. So all adults need at least 1 dose. But in order to attend school here in the US, you need 2 doses of measles vaccine. One is good, and the other one just boosts the immunity. So we really do recommend the 2 doses. And as far as I'm concerned, all adults are really kind of high risk, because if you're around children who may not have been vaccinated, we want to make sure that you have a good response. The reason why we recommend the 2 doses is because 5% of the population does not seroconvert from only 1 dose. We found that out from the military data. And then after a second dose, all but 1% seroconvert. So it's really good vaccine, and we really want to make sure that everybody gets the vaccine so that they don't get sick or make someone else sick. And there has to be 28 days between the 2 doses. And that's because these are live virus vaccines. They're attenuated, but they are live virus vaccines. And if you give them too close together, the immune system does not recognize the 2 separate vaccines the way the IgG and the IgE start to rise. So that's why you have to have them separated by 28 days. Okay. That one we don't need. I forgot to eliminate that one. Varicella vaccine, chickenpox. Everybody says, not really a bad disease. Well, it's really not such a horrible disease for most children. They itch, they can get scars, but they kind of recover pretty well, unless your child is one of the children who comes down with necrotizing fasciitis from an infected chickenpox, or if your child comes down with chickenpox pneumonia or chickenpox meningitis, or disseminated chickenpox, which means that the viral load is so high, every single organ in the body is infected, and those children don't survive. And adults, excuse me, who come down with chickenpox, 30% of adults who come down with chickenpox go on to develop chickenpox pneumonia. So if you've never had chickenpox and you don't know if you've had it, you really should be vaccinated. You can also ask for titers if you want, but the problem with asking for titers is we don't see as much chickenpox in the community now because we do such a good job of vaccinating the children. So if you were vaccinated, if you had disease, your antibody levels may very well have started to drop because you haven't been exposed. So CDC generally recommends that you get vaccinated if you're not sure, especially us healthcare personnel, because again, we don't want to give you anything, and we need to be the poster children for vaccinations. Now, influenza vaccine, we have 2 new strains in the vaccine this year. The H1N1, The H1N1 is the one that's been around. This is the 3rd year in a row that we have the H1N1-like vaccine in it. But these 2 are 2 new ones, Victoria and Wisconsin. So and it's really, I'm going to tell you how we decide what we're going to put in the influenza vaccine. The epidemiologists and the infectious disease docs look at the chickens and the ducks in Asia in January or February of each new year, and they look to see which viruses they're carrying. And that's how they make an educated guess to determine what virus strains they're going to put in this current year's vaccine. And that's why they made the change. In fact, as I was coming in here and coming through security, I had a very interesting conversation with the lady in the security, whatever they call that little office that she has over there. She said, "Oh, I don't think I want that vaccine." She said, "They just infect you with flu, doesn't it?" And I said, "No." I said, "The influenza vaccine, the one that we give to most of the adults, is killed. It's dead. There's no way that it could possibly give you influenza. It can give you mild influenza-like symptoms, like you might get a little headache, you might get a little joint ache, you might get a little stuffy nose within the first 3 to 5 days of getting the vaccine. If it's anything more than that, it's not from the vaccine." I've also had people get vaccinated, and because the vaccine, the killed one, takes 2 weeks to work, you can come down with influenza before the vaccine starts to take effect. So I think we as healthcare providers need to tell people who are taking the vaccine what the side effects are and how long it takes to work, so that they have a realistic expectation of how the vaccine is going to work. It's not one of our better vaccines, but it's certainly better than nothing. I had influenza when I was in graduate school. I thought I was going to die. I was taking pharmacology, and I had to go to school every week. Otherwise, I wouldn't be able to get my license to write prescriptions. And all you heard on my tapes, because you know, it was so many, we used to tape the lectures, and all you heard on my tapes was, but I was really sick for 3 months. I went from bronchitis to pneumonia to reactive airway disease following influenza. And I think it's probably because I didn't stay home and rest like I should have. But it's really, an influenza, what would you think if I told you something was killing 36,000 people in the US every year? That's how many deaths we see annually from influenza disease. And those are the only ones that we can clearly link to influenza, because we lose so many of our folks 60 and above from pneumonia or complications related to pneumonia when they, if you really look back, they had influenza to start with. So we don't even, that's probably just the tip of the iceberg. Okay. Now, there's also the Fluzone high dose for those 65 and older. As we age, our immune system ages along with us, so we don't respond as well to the vaccines. So what they're trying to do is they've developed a new vaccine. Well, it's influenza vaccine, but it contains 4 times as much of the hemagglutinin, which is what stimulates the immune response, that we're trying on those 65 and older to see if we can kick their immune response up, because senescence definitely affects how we react to the vaccine. And it's the 65 and older who are the most likely to die from influenza disease. So we're collecting, we've been using, this is the 2nd year now in a row that we're using the high-dose vaccine, and we're going to be looking at the data to see if we get a better immune response and we see fewer deaths in this age group related to this vaccine. The one big thing that we have to remember to tell folks when they get it is it can increase the redness and swelling in the arm following the vaccine, because it does have more antigen in it than if you get the regular one that most people are going to receive. Now, we also have a new method of giving vaccine that started last year. It's called intradermal. And if you look at that little teeny tiny needle at the end there, that's all the needle is. And it's given in the same spot as the influenza vaccine is, in the deltoid area. But a lot of people like it because they are not as afraid of the needle, because the needle isn't as long. But it does come with a little bit of a side effect of more redness and swelling than if you use the deeper, the longer needle to give it intramuscularly. Then we also have what we call our live attenuated influenza vaccine, which is it's a flu spray, or better known as flu mist, and it's approved for anybody healthy 2 through 49 years of age who's not pregnant. Healthcare workers can get it. Anybody who has contact with high-risk groups can also get it, as long as those persons are living in the community. This is really great vaccine. We almost exclusively use this for the children less than 18. First of all, you don't have to get pinched. Second of all, it works better than the shot in the children. Again, as we get older, our immune system doesn't work as well, so that's why it's only licensed up to 49 years of age. Because when they looked at the data, as people approached 50 and older, they didn't get as good an immune response to the mist as they do to the shot. But it's certainly an alternative. If you don't want a shot and you're within that age range, then you could ask for the mist. Now, everybody was always worried about, well, when are we going to give influenza vaccine? Most of the influenza disease that we see, the activity doesn't occur until January or later. The past couple of years, it has been a February peak. So it's never too late to get your flu vaccine. But like I said, the sooner you get it, the better, because it takes 2 weeks for the shot to work, and it takes 5 to 7 days for the mist to work. So that's another advantage, too, to the mist. It works a lot faster. So we have started offering influenza vaccine as soon as it became available. I will tell you, your local pharmacy is a great place to get an influenza vaccine if you'd like. Those pharmacists took the exact same courses as we nurses took from the Center for Disease Control and Prevention. They went through a very rigorous program here in New York State of return demonstration in order to learn how to give influenza vaccine. And I actually witnessed a couple of them giving it. I was in the drugstore waiting to pick things up, and there was the pharmacist. He came out with his vaccine information statement. He went through his whole little teaching thing with the person he was vaccinating, and then he went over the after effects and what to do and if something occurred, and then he sat them in a chair, and I watched his technique, and his technique certainly was as good as mine. The only objection I had was I think he needed a screen because we forgot about the privacy issue. So I said to him later, I said, you don't know who I am. I said, I wasn't planted here as a spy, but you did a really fine job, and I was really impressed. The only thing is, could you please get a screen, because I think everybody deserves to hide behind a screen when they're getting a shot. So he giggled and laughed at me, and he said, gee, you know, we forgot about that. When I came back, he had a screen there for, for all of the other vaccines he gave. But like I said, I would not hesitate 1 second to have a pharmacist give me a flu vaccine, or any of the other vaccines that they're currently licensed to give. Because now they're able to also give in New York State the pneumonia vaccine and the zoster, or the shingles vaccine. All right, now, contraindications, we always want to have truth in advertising here, so I'm going to tell you what the contraindication is to influenza vaccine if you've ever had a severe reaction to the vaccine in the past. We used to think egg allergy was a contraindication to influenza vaccine, but when we started looking at that, we realized it's really not a contraindication. And the reason why we thought it was because all of the influenza vaccine administered in the United States is grown in sterilized chicken eggs. So we were afraid that the white part of the egg, which is the contaminant part that would cause the allergic reaction, might potentially cause an allergic reaction in someone who had a severe allergy to eggs. So now we're looking at that much more closely. And unless you have a severe anaphylactic reaction to eggs, you can safely get influenza vaccine. The other precautions would be moderate or severe acute illness. For me, it's like the wet dishcloth child, or if an adult was really seriously ill with, say, maybe like pneumonia or a really bad cough illness with a fever, I would hold the vaccine for them. But generally speaking, most people are healthy enough to get vaccinated. Or if you've had Guillain-Barré syndrome within 6 weeks after you got a previous dose of influenza vaccine, again, both very rare. All right. Now, for the mist or the spray, the precautions, contraindications and precautions for that one would be if you have a child less than 2. And the reason for that is because we did see some wheezing illness in children less than 2 years of age when they got the flu mist, or an adult 50 or older, and I told you why, or if you were immune suppressed, or a child taking aspirin therapy, or a pregnant lady. We don't give any live virus vaccines to pregnant ladies. If you've had a severe allergic reaction to a prior dose, or if you're any children 2 through 4, or anybody with asthma who's had a wheezing episode within the past year. I'm a primary provider in Maxine Postal Tri-Community Health Center in Amityville, and I have several children with asthma that I give flu mist to every year because they're so well controlled they haven't wheezed in years. So, and the reason I prefer to give them the flu mist is, as I mentioned, it works much better in the children than the shot does. Or the history of GBS within 6 weeks, or a moderate or severe illness. Hep A, I'm just going to mention to you, I mentioned to you before, if you eat sushi, you really should get hepatitis A vaccine. It usually is community acquired, and it's the children who carry it. Usually we find out we have Hep A in the community when we find an outbreak at a daycare center, with the adults, with the providers. And it's because a child had it. Kids don't get sick usually at all from hepatitis A, but big people can get very sick. All right. Meningitis vaccine, something else that we want to talk about. If you've ever met a mother of a child who died from meningitis vaccine, you're going to want to vaccinate everybody. So anybody who has HIV and is being vaccinated with meningitis vaccine gets 2 doses. So anybody whose immune system is challenged needs 2 doses to invoke the immune response, separated by at least 8 weeks. Reason for that was when we started looking at the data, we found that they just didn't get a good immune response after only 1 dose. Now, HIV is not an indication for meningitis vaccine, but if you have one of those other indications and you do have HIV, then you do need 2 doses separated by at least 8 weeks. And my favorite example of that is the adolescent. If you've got an HIV-positive adolescent who needs to be vaccinated against meningitis, that child's going to get 2 doses followed by, separated by 8 weeks. Or anyone who's traveling. Because, you know, if you're going to go to the Hajj, meningitis vaccine is required before you can enter Saudi Arabia. So, and if you're going back on a regular basis, then it would be repeated at 5-year intervals. Right. Now, this is a big one. This is pneumococcal vaccine. This is our pneumococcal polysaccharide vaccine, or 23-valent, which means it covers 23 strains of pneumococcal bacteria, and it's recommended for all unvaccinated adults 65 and older, and any adult 19 through 64 with a chronic condition, such as heart disease, pulmonary disease, which now includes asthma, diabetes, alcoholism, chronic liver disease. Anybody who's got a challenged immune system for whatever reason really should get the pneumococcal 23, and cigarette smokers. Now, the cigarette smoker does have to be 19 through 64, because when they looked at the data, those who were younger and were smokers did not have the same risk as those who were older. So these are the new recommendations for adults at high risk for invasive pneumococcal disease. All adults should get 2 doses separated by at least 5 years, and these are the conditions: any type of asplenia, C.S. Efley, cochlear implants. That's a big thing now. Anybody who's going in for a cochlear implant is recommended to get the pneumococcal 23 before they go into the hospital, and for any kind of immune suppression. Now, revaccination. Anybody who got 1 or 2 doses before 65 for any reason gets another dose at 65 if it's at least 5 years since the last. Now, this pneumococcal 23 is not as good as the Prevnar or the PCV13 that we give the children. Any of the polysaccharide chain vaccines don't work as well as the conjugated ones, and PCV13 is conjugated. It just invokes a much better immune response. When you revaccinate with the pneumococcal 23, you get a fairly decent response with subsequent booster doses, but it's not as robust as if they had gotten the conjugated vaccine. Conjugated vaccine, when you give a repeat dose, it's as good as the first one. But with this one, it's not quite as good. But again, it's the best thing that we have to offer, so that's why we offer it. It's certainly better than going without anything at all. Now, we're also offering PCV13 in some situations to adults. So on December 13th, in December of 2011, it was approved for use the vaccine was approved for adults 50 and older. And the FDA was so impressed with the data, that's why they put it on the accelerated approval pathway for this vaccine. So when they looked at the data, they found that the PCV13 worked. Well, you guys are all scientists, so you know with the non-inferiority studies. So they found that it worked as well as the PPV23 for prevention of pneumococcal disease. When you look at the data, go back to that NHANES data to see how many people die of pneumonia in this country. It really is terrible. Jim Henson from the Muppets, the Muppets creator, died from complications related to pneumococcal pneumonia. Now, this one, if you look at these 2 conditions, HIV/AIDS and cancers, you see this big risk here. There's a 20-fold increase. So that's why this specific group is really recommended to get the PCV13. Now, the other advantage to PCV13 is it prevents carriage. You don't carry it in your nose. The 23 does not prevent carriage. So if we vaccinate these folks who have these challenged immune systems, we're not only preventing them from getting disease, we're also preventing them from having carriage, which they could become infected either themselves or infect someone else. But the problem with 13 is, by itself, because it only covers 13 serotypes, it's not as effective than when we use it in combination with the 23. This is brand new, hot off the press. In fact, the official MMWR just came out last week. We got the press release, I guess, about 3 months ago. But the MMWR, which is what a lot of the insurance companies wait for before they say they'll pay for the vaccine, was just published last week. So anybody who's never had any of these vaccines in the past, and they're 19 through 64 with any of those immune-compromising conditions, gets a single dose of PCV13 followed by the PPSV23 at least 8 weeks later. And then they would get a second dose of the pneumococcal 23 5 years after the first dose of 23. Now you see why I say all the docs need to keep a copy of the schedules right at their fingertips when they're seeing their patients. The third and final dose is recommended at 65 or older as long as there's at least 5 years between the second dose of 23. This is just our little algorithm of how we decide who gets how many doses. All right. Now, for any adult that was previously vaccinated with those immune-compromising conditions, they get 1 dose of 13 at least 8 weeks after the last dose of 23. And anybody who requires the 3rd dose, you've got to have at least 8 weeks again between the 2nd doses. Now, this is the shingles vaccine. Everybody's really interested in this one. One of my very good friends, her mother-in-law had one of the adult leukemias, and we know that the adult leukemias do put people at risk for development of shingles because it's the immune system is not as robust related to the cancer. She came down with shingles, and she died a year after she came down with shingles because it so changed her quality of life. No matter what they gave her, they could not keep her comfortable. And Lee believes that her mother-in-law really just gave up. She was just tired of being in pain all the time, so she just gave up. So this is really a quality of life issue. And it's caused by the inactivation of the latent chickenpox virus that lives in our nerves for the rest of our lives. And it can happen years and years and years after you've had the illness. And it's usually associated with aging or anything that challenges the immune system. We see it occasionally in children. Most of the time, if we see it in children, it's because they have an compromised immune system for one thing or another. Now, we have an estimated about 32% in the U.S. of zoster occurring. That is a lot of people, and about 50% of those cases are 60 and older. So you see where I'm going with this. Okay. Now, the contraindications are allergic reaction to the vaccine, pregnancy. Well, most 60-year-olds are not pregnant unless you're one of those people who, all those interventional things. But, so I guess that's why they said pregnancy, or if you're severely immune suppressed. Now, immune suppression, it depends on what your CD4 T cell count is, whether or not you can get the vaccine. Because Lee said if her mother-in-law had gotten that vaccine before she came down with the zoster, she would have been a candidate for the vaccine. So that may very well have improved her quality of life. So ACIP recommends a single dose for those 60 and older, and the age indication was expanded to 50 through 59, but ACIP decided not to recommend generally 50 through 59. And one of their big reasons was the statistics show that more of the cases are 60 and above, but also the cost of the vaccine is $300, number one. And number two, it's hard for the company to make because they have to use an awful lot of antigen in order to make the vaccine, and they were worried that it would decrease the amount of chickenpox vaccine that we would have available for the children. Because if we can keep the children from getting chickenpox, that also keeps people from becoming infected in later years. We also have really good data that shows if you get vaccinated against chickenpox as a child, you have a lower chance of coming down with zoster as an adult than if you had wild chickenpox disease. Now, I had wild chickenpox disease as a child, so my chances of coming down with zoster are much worse than my grandbabies who are getting the vaccine now. My own children had the disease, so they're in the same boat that I'm in. And actually, what the vaccine is for, it works it's probably about 75% effective against preventing zoster, but it's 86% effective against preventing the postherpetic neuralgia. So that's really why you get this vaccine, is to prevent the postherpetic neuralgia, because the pain is excruciating. And you can see it. It's usually that cluster of little blisters right along the nerve root. The most common place we see it is right along one of the thoracic nerve roots, and it's only on one side. If it goes across to the other side, it's not shingles. Now, the screening. We asked, the CDC is, because you'll read the package insert, and the providers read the package insert. They really need to go to the ACIP schedules and all those footnotes that I showed you in the first place to decide whether or not, what kind of screening that they're going to do. Screening for history for disease is not necessary or recommended, because if you were born before 1980 in the U.S., it's generally accepted that you've had chickenpox or have been exposed to chickenpox. So that's why, we don't want any titers drawn. Because remember what I said to you before? They're going to start drawing titers on people, and they're going to see low titers because there's not a lot of chickenpox in the community. And once you get those low titers, then you have to give 2 doses of chickenpox vaccine first before you can give the Zostavax, which makes absolutely no sense. It's not cost effective. So if you were born before 1980, you are a candidate for this vaccine. Now, again, the contraindications and precautions would be the allergy, pregnancy, or immune suppression. Moderate, and then the precautions are, again, as I've been speaking all along, if you were a moderate or acute illness, or if you were receiving current treatment with an antiviral drug against herpes virus, you have to wait 24 hours before the administration of the Zoster vaccine. You got to stop it and then 24 hours. Because there are people on immune suppressive therapy for herpes viruses, so you have to ask those questions. And then we really shouldn't start the antiviral vaccines again until 14 days later. And if you've recently had a blood product, that's not a precaution for this vaccine. Now, there was some data in the package insert that said you should not give the 2 vaccines together at the same time, the pneumonia 23 and the Zostavax. But we have a recent study that said increased risk of zoster in persons who got both the zoster and PPV on the same day there was no evidence for that. So there's no reason why we can't give the 2 on the same day. I work for the health department, and we are always looking for best practices to maximize people being vaccinated and making it convenient for you. So we always try to give as many vaccines as we can in the one visit. You don't need to be taking 14 days off from work to come and visit us. So we want to give you the best vaccines, the most optimal intervals, and the most expeditious time frames. So recommendations are remaining the same, and both vaccines can be administered at the same time, in 2 different arms. Now, these are my 2 grandchildren. That's Luke. This is Luke on the right, and that's Henry. And their mommies tell me that they're having them immunized on time, every time. And I hope you and your families will too. And thank you very much for your attention. And thank you so much for inviting me here today. If anybody has any questions, I'm happy to answer them for you. Now, because of the budget cuts this year, we are not offering any influenza clinics, but if you want the tetanus acellular pertussis booster, we have a grant program that we received the vaccine for free. And the way we administer that is through my Shots for Tots program. So if you are interested in that, our phone number is 854-0222. You can call us, and we'll tell you where you can come and meet us, and we will be happy to give you the whooping cough vaccine. Okay? And there is no charge at this time for that vaccine because we got it as a grant. So we're really happy to be able to provide that for the public. Okay. The chickenpox, and you should check your health insurance for the zoster vaccine and for the pneumonia vaccines. Like I said, you guys are federal government employees, and my understanding is your insurance covers most of the vaccines. Anybody else? Yes?
Say a healthcare provider received the hepatitis B series and they have proven immunity. I've heard that immunity wanes over time, so should they be checked again? Their titers, and if so, what's the time, period?
I'm so glad you asked that. When hepatitis B the vaccine is really excellent vaccine. And you're absolutely right. When there isn't an exposure over time, the antibody levels start to drop. But this vaccine has what we call immune memory. So if you get stuck with a dirty needle, your immunity is going to start rising again and you are protected, because the data indicates to us that anybody who received the full series of 3, it's like 99.9, because we can never say 0, never goes on to develop chronic hepatitis B. But the problem is if you get tested, and once we see it on paper that that your immunity has waned, then we are forced to give you the whole series over again, which just is not cost effective. So what the recommendations from CDC are is that we don't test. We just give you the vaccine, and for the general lay public, we don't test again. Now, I have my hepatitis B antibodies from 20 years ago when I got the vaccine. Probably if you tested me now, my studies would have fallen. But what I would say if I went to another job is, here it is, you know, that says I'm immune, so I don't have to be tested again. Another question? Yes?
I had a TB 11 years ago, and this year, doctor suggested to get a booster.
Yes.
So I should get Tdap, not a TB this year?
That's right. You should get Tdap, and he suggested Boostrix for you, which is usually, you know, when we do the lectures, I usually don't put the trade names. There's 2 currently licensed Tdap vaccines, Boostrix and Adacel. Both are licensed for adults, and he obviously had Boostrix in his office if that's what he offered you. And Boostrix is actually the one that's licensed for 10 through the entire lifespan. The Adacel is licensed for 11 to 64, but as I mentioned to you, we pretty much use them interchangeably. But yes, you should, because you really don't want to get whooping cough. Yes, you should call him back and say you need the Tdap. Okay? Anyone else? Well, I want to thank you again very much for your attention and for inviting me here.